Orrin Troum. I'm here at the Rhuematology Winter Clinical Symposium on Maui. And yesterday I gave a talk along with Marty Bergman about the updates for 2015 and going into 2016 on what actually was presented last year at EULAR and ACR and published in the New England Journal of Medicine. And one of these related to osteoarthritis and some of the newer data that was presented last year. One of them had to do with hydroxychloroquine, and there are many people that still use hydroxychloroquine for hand osteoarthritis. There was a very nice presentation that was demonstrated at EULAR last year that suggested this is just not effective for hand osteoarthritis. There are 200 patients, some got 400 milligrams of hydroxychloroquine, others got placebo, and there was no decrease in hand pain in this group. So I think that was a highlight because we have no real treatment for disease-modifying therapies for osteoarthritis, and this suggested that hydroxychloroquine or Plaquenil doesn't work. There was another study that looked at something that we frequently do for osteoarthritis, and that's inject corticosteroids. So they looked at patients that had osteoarthritis of the knee, that had a Kellgren-Lawrence grade 2 or 3, and that had demonstrable synovitis of the knee that was demonstrated by ultrasound. And the question is whether or not we can continuously give these patients injections of steroids versus doing a surgical procedure. Well, some patients don't want surgical procedures, and others can't get surgical procedures due to some other comorbid condition. So this was a very nice study looking at triamcinolone, 40 milligrams, given every 3 months for up to 2 years. These patients also had annual MRIs of their knee, 3 Tesla MRIs, that looked at structural progression. And what it showed was that patients that got 40 milligrams of triamcinolone intra-articular every 3 months for 2 years had symptomatic relief, but did not have any significant structural progression. There were some minor fibrillar changes seen by MR, but this gives us some information to say it's okay to inject these patients if they either can't get surgery or don't want to get surgery, at least for up to 2 years. There were 2 other studies that I'll mention. One had to do with total knee replacement, and this was published in the New England Journal last year. It was very interesting thinking that, well, can we use non-surgical therapy versus surgical therapy, and who actually does better? And the outcome of this study was that patients that got total knee replacement actually did better over this period of time, where they had improved quality of life, they had improved activities of daily living, and the patients that were trying to do as well just with non-surgical therapy did not. But this comes with a cost, and this was something that I really haven't seen in my practice but should be known, that patients that undergo total knee replacement are at an increased risk of a myocardial infarction, and this lasts for up to 6 months. And so that has to be taken into account. You should really assess your patients from a cardiovascular standpoint before they go for a total knee replacement. Interestingly enough, over that 6-month period, then that increased rate of MI seemed to peter out or come down to a normal level, but the risk of venous thrombosis did not. So once you had a total knee replacement, you're more likely to have a thrombotic event, and that should be remembered for the life of that patient. So these are some of the highlights, at least from an osteoarthritis standpoint. I would just encourage you to come back and join us next year to the Rhuematology Winter Clinical Symposium 2017. It's a great clinical meeting. We'll look forward to seeing you.